Having a patient with giant cell arteritis also means that when you treat them, you give them high dose at first, but then you taper it down over a long period. Remember that too many steroids in someone's body can cause glucocorticoid-induced myopathy, also known as GIM, and this causes hyperglycemia, it can cause bone loss, it can cause myopathy, of course, just like the name says. Remember that these myopathies are typically chronic, they usually don't happen very acutely, and this is because steroids in general are catabolic and it causes muscle catabolism and decreased anabolism. The type of myopathy really presents as proximal weakness. And they won't tell you this directly, of course, but basically the patient will have trouble getting up from a chair or difficulty raising their arms more after they brush their hair. And this is really important to remember that the CK and the ESR of the patient are not going to be elevated. At what times will you see elevated ESR or CK? That's when you want to think of polymyositis and dermatomyositis. If it's just ESR that's elevated, remember polymyalgia rheumatica, while creatine kinase will be normal. And when you have a normal ESR and an elevated creatine kinase, hypothyroid myopathy should be on your differential. Inflammatory types of myositis are symmetric proximal muscle weakness, and you'll also feel tenderness to palpation. And like I just mentioned, CK and ESR are usually elevated. There's also a pretty high yield topic on step 2 mononeuritis multiplex. It's basically seen when you have vasculitis, and this causes nerve damage in separate parts of the body, and your patient will kind of present as this weird asymmetric peripheral nerve finding, and they usually like to use some sort of muscle drop like wrist drop or foot drop in the prompt. And never forget that if your patient is presenting with neurological symptoms with differences in space and time, this is multiple sclerosis.